Thanks, George, for the invitation. And we start my presentation. The order is changed because I think it's better to speak before MRI because it's introduced in the clinical practice, everyday clinical practice, this technique, and there is a wide number of articles about this topic. And surely there are some radiologists in the audience? Radiologists in the audience? No radiologists? How many radiologists in the audience? Okay, sorry about this. I'm a gynecologist, but I have to speak about this because we use, in collaboration with the radiologists, in several cases, the MRI. And from the anatomic point of view, it's a good technique. It's perfect because it's very wide vision of the pelvis. But the problem is the duration of the examination, the necessity of fasting, 5 hours, more or less, and also the possibility the administration of peristaltic inhibitors, because the bowel is moving organs is very problem with MRI. And we don't use rectal or vaginal US gel in the usual practice, but we use the T2. Our radiologists use T2 for the detection, for the morphology, and T1 just for one plane for the signal, hyperintense signal of the blood. And usually we don't use contrast material or any kind of contrast material. This is reduce the time of the scan. As for US ultrasound, transvaginal ultrasound, the nodules are different aspects. For example, there are similar nodules, true nodules, or star for the presence of this is the top. Okay, thanks. Sorry. Nodules, stars for the presence of adhesion, also a typical hourglass sign with 2 nodules near. And the uterosacral ligament is a typical aspect because it's normal aspect. It's like mustache. It's unusual for us as gynecologists because it's difficult to find normal uterosacral ligament. But for the radiologist, it's easy because there is very simple aspect from the anatomical point of view. And in case of retraction, this is a typical image for the radiologist. And the accuracy is good. This is another case of uterosacral ligament involvement, and the sensitivity and specificity is very good. Vagina is not so easy, but in case of hyperintense spot, it's easy to identify, but it's not always present in this kind of nodule. The specificity is good, the sensitivity is depend. And the bowel endometriosis is a typical sign of double nodule. It's hourglass sign, we call in this name. Is other authors call this very simple to visualize sign. And this is also in sigmoid, where is the involvement of the bowel in several planes. This additional plane and this one very big nodule by MRI. And the effect, the same way we can see by ultrasonography, the traction of the different organs is very a typical sign of deep endometriosis. The results are good also using MRI in the bowel endometriosis. And this is additional techniques. We use the magnetic resonance colography. It's very interesting to study the percentage of luminal reduction. This could, if in Italy, usually, just in case of big reduction of the lumen, we do surgery for this kind of resection, because the consensus is not so simple to obtain from the consent is not so easy to obtain from the patient in case of risk of derivation. And we study for several years the effect of learning curve, because as gynecologists we send to the radiologist, but the radiologist for the radiologist is fundamental, the experience about this kind of pathology. And for this is probably fundamental to select a team of good radiologists involved in this kind of diagnosis. And the relationship between radiologists and gynecologists is fundamental, because we have to speak, verify every case, and there's very, very improvement of your diagnosis. Also the time of examination decrease depending of the experience of the radiologist. And also increasing the experience, increase the possibility of good diagnosis from a radiologist, experienced radiologist. And this one the last paper about this, and we studied the relationship with different radiologists with different experience in this field, and we observed that in some locations it's very difficult for younger radiologists to obtain a good diagnosis. For example, uterosacral ligament is difficult, but vaginal fornix is difficult. Also, in some localization of recto sigma, the younger radiologists have more difficult to obtain a good diagnosis. The reproducibility of these techniques is good, usually, also for different kind of radiologists. And we use in everyday clinical practice these techniques as protocol, also for investigational purpose, but we obtain unusual results, because we obtain that in using both techniques, we increase the effect of these two. It's a complementary effect. We increase additional effect in terms of results. And for this, we use both techniques usually, because I think it's not against MRI against transvaginal ultrasonography, but probably increase the capability of both techniques for to obtain a good diagnosis. And we change another field of our presentation is 3D. 3D is one of the additional techniques possible using MRI, using transvaginal ultrasonography. Is probably the last one, but there is a few studies. I published some years ago the first study about this topic, and it's an interesting field for us to obtain volume to revise year after year during, for example, a follow-up of the patient. And this is the image. This is a nodule, this is a bowel, these are similar. We obtain the coronal plane. This is very difficult to obtain, usually a coronal plane using conventional 2D transvaginal ultrasonography. This is the tomographic view. It's very, with a lot of additional information with the relationship with the, remember, no? The hyperplasia of the submucosa, the muscularis, there. This is hypertrophic. This is the relationship with the ureter, the nodule, and the distortion of the ureter, the medialization of the ureter. This is a vocal with the volume. It's a good, usually the nodule is like this. It's very complex nodule. This is our techniques with the tenderness and the additional amount of gel inside the probe. This is the vagina there, and this is the uterus there, the fornix. And we perform a simple study comparing 2D with 3D transvaginal ultrasonography. And I have to present tomorrow. I will present tomorrow this, but it's a study performed in more than 200 patients. And this is the results in terms of images. This is a double nodule. Is also in this case is difficult. French researchers call this diabolo-like nodule because it's very difficult for laparoscopists. It's very difficult to remove. This is the vagina, and this is the nodule in the vagina and the nodule in the bowel. And this is the Indian dress with the retraction, and this is another kind of nodule, and this one, and this interesting plane. This is the coronal plane. It's fundamental because it's derived from. It's impossible to obtain this plane using 2D. And this is a typical reaction like this with a lot of retraction, and this is like a toy windmill in this English translation. This is very a lot of retraction all around, similar to the coronal plane using, for example, mammary glands and other kind of 3D images. This is a totally unusual image for us. Is a new image. This coronal plane and this is the lateral plane of the same nodule. It's completely different aspect. This vaginal septum, a vaginal nodule. This is another unusual aspect, the coronal plane of the uterosacral ligament. This is the nodule with a longer stripe there, and this is the nodule inside the uterosacral ligament. The localization is made using 2D, obviously, but the increase of information obtained using 3D is a reality. And for example, this is a nodule with this is the increased amount of gel inside the cover probe. This is the nodule. It is similar to the image of Cullen a lot of years ago. This is the nodule, the same nodule in the posterior fornix. The effect of the comparison of the techniques is no difference in the case of rectosigmoid localization, but in case of other posterior localization, there is an increase of sensitivity. And it's a good increase. And the specificity remain practically the same. And this is the improvement of the receiving operating characteristic curve using 3D images. Also, the inter-observer is good in terms of reproducibility. And this is another technique that we use, the introital for rectovaginal septum. We use is similar to the technique used by urogynecologists. This is the vagina there. This is a nodule. This is the specificity. The idea is from my colleague Pascual from Barcelona, and also performed a study of about the reproducibility, and the results are really good. We use another procedure using vocal, and this is we made a sphere inside the nodule, and we obtain relatively obvious results. The nodule of the rectosigmoidal nodule, due to the presence of reaction of muscularis, are more consistent. The value, mean grain value, are higher in comparison of retrocervical nodule. Also the reproducibility is good. We also compared in a small series, MRI, 3D and 2D. The results for rectal sigmoid localization are similar, but in case of other posterior localization, probably due to the presence of better capability to understand, to evaluate the uterosacral ligament lesion, we increase this approach using 3D in comparison with 2D, with a similar results in comparison with MRI approach. And thanks for the attention.
Thank you, Stefano. Are there any questions?
So what I'm trying to get my head around, Stefano, is if you can, when you look at the performance of ultrasound to predict, 3D ultrasound to predict nodules, I presume, how do you remove the fact that you've already done a two-dimensional scan before you do a 3D sweep? So I suppose what I'm saying is, even before you do a 3D
recall
sweep.
bias.
That's what I mean, yeah.
Recall bias, yeah. We wait 6 months
and
after,
then,
yes.
And then at 6 months, you then go over the volumes and
yes.
then re-look at the
yes.
volumes.
I have a bank of volumes.
Yes.
I return over the volumes and reanalyze the volumes. It's impossible to remember the original 2D. It's a problem with the recall bias, but I try to avoid it with this option.
And then, obviously, because you're an expert at evaluating 3D volumes, have you then looked at how reproducible that is with other observers?
I perform a study about reproducibility. Is probably one electronic poster in this Congress, and spend time to speak about with other young colleagues or residents about this 3D, and she do the same protocol than me, and the results are good. Initial good are good, but after 6 months of increase of this slide, this one, and after 6 months, the specific training increase further the kappa value. It's an initial good results. It's fundamental to, obviously, is a specialist in this case. It's not so easy. But the major problem is, as a specialist, usually I review, for example, images of other colleagues. There is, for example, a typical nodule, not described for the colleague. There is a picture of the nodule in the retrocervical part of the uterus, but without description. This, if you know the presence of endometriosis, as my colleague Savelli say, think endometriotic. You have the idea to search endometriosis. Probably you have all kind of possibility to obtain this kind of diagnosis, because it's not so difficult in the everyday clinical practice. But the colleague performed perfect picture of the nodule, but without description. In Italy, is usual this approach, because it's probably, I don't know, because no explain this unusual part of the, for example, intestinal nodule. It's a strange situation for us, but if you think endometriotic, you have a possibility to obtain a lot of additional diagnosis. Obviously, 3D is another specialty. Is a part of the big world of transvaginal ultrasonography in the deep endometriosis. But it's interesting in this moment, because some coronal plane are very important to obtain. It's an unusual plane. The coronal plane is surely a good plane to obtain some information, for example, for uterosacral ligaments. Decrease the number of false negative.
No problems. So thanks very much. We'll leave it there. Can you thank Thanks, Stefano, for his presentation. Thanks.